Good morning. I am Walt Lubbers, and this is EMS Grand Rounds. This is the Winter Exposure Injuries Studio Edition, in that the recording that we started this morning didn't actually take, and so I get to re-record mine sitting here in an office instead of in front of a bunch of people, which is cool, but it may be a little different than you might have seen this morning. Hopefully a little bit better. Hopefully not a lot worse. But I'm going to talk about winter exposure injuries here. So it is currently February in Lexington, and it got cold last night, down into the 20s, and it's not going to get much warmer than freezing today if it gets warmer at all. So it seemed like an appropriate time to go ahead and talk about this, especially since winter's almost over, and if I give it next month, we're going to be talking about spring exposure injuries. So here's your list of objectives. We'll kind of talk about some of this stuff. Hypothermia generally occurs, at least in the U.S., to two groups of people, and that's old folks and little babies. Old people because they have less reserve, less thermoregulatory response, and babies because they have a high surface area. So a baby will get hypothermic almost at the drop of a hat. If you sprinkle them with water, they can become hypothermic. Old folks tend to have lots of comorbidities, heart disease. They tend to be on a lot of drugs that mess up your thermoregulatory response. So old guys and babies are the ones that we often see it in. Everybody else, in terms of the middle-aged folks, you have to be either too crazy or too drunk to come in out of the environment, and those are the guys that we see with hypothermia. You could add to that list too injured. So if you're trapped in a car upside down in a creek and it's the middle of February and it's snowing, of course you might get hypothermic. But our trauma patients will do this very quickly. If you notice, most trauma patients that come in, they're not 98 on their temperature. They're somewhat less than that. Maybe it's 96, maybe it's 95. But as soon as you get severely injured, your body starts to gravitate down to whatever the ambient air temperature is. So if you are unable to rescue yourself, again, either because you don't realize it or because you're too intoxicated, then those are the guys that are going to be more at risk for actual hypothermia that we'll see from an EMS standpoint. It's also worth noting that there's not a whole lot of hypothermia deaths. There are, but per capita, there's not that many hypothermia deaths up in the north. This state, Colorado, Arizona, North Carolina, South Carolina, those are where a lot of a high population of hypothermia deaths actually occur, and that's because those are states with variable climates. So if you think about Colorado or Arizona, where it is 90 degrees during the day or 85 degrees during the day in the middle of January, and then drops down to 30 at night after the sun goes down, you can see how people might get caught outside unprepared or unacclimatized otherwise and be unable to protect themselves, and so they might get hypothermia. So higher chance of death from hypothermia in places where there's a mild but variable climate. So we'll talk about hypothermia itself in just a minute, but it's worth mentioning the extremity components of exposure injuries as well. And you can divide those up into the freezing versus the non-freezing injuries. So freezing injuries require the skin to be frozen, and the non-freezing injuries we'll talk about right now, they don't require the skin to be frozen. Imagine that. So one that you'll see fairly commonly if you're working in EMS or working in the emergency department is immersion foot or trench foot. And this particular person is not as bad as they look. I think they've actually got toenail polish on. Their feet are not as ischemic as you might think they are. But you can see this common presentation of blisters and hyperemic skin with some numbness and some blanching areas around it. And this is common day. This is not a person who you would commonly associate it with, which is the soldier in World War I. And you can see how it got the name trench foot. If you're sitting in the trench, it's basically full of water. It's not particularly warm in France in World War I for most of the time. And so the soldiers basically had the choice of either standing in ankle to knee-deep water or standing up and getting shot. So they get exposed to prolonged cooling and wetness on their feet. And this is almost always on your feet because that's the place that stays cold and wet for the longest. Everything else we do something about. But where we'll see it now is not so much in soldiers, but in homeless folks that are stuck outside and can't get to dry shoes or can't dry their feet. You might also find this in people that are stuck outside, so hikers who get caught in a rainstorm, have to stay out in not freezing but certainly cool conditions for a long period of time can certainly get this as well. The actual pathologic process is a combination of ischemia, because when your feet get cold, your blood vessels shrink down, and then ischemia and inflammation after that happens. And keep in mind, these are folks that are exposed to a fair amount of water for a prolonged period of time. And so your feet stay ischemic for at least a decent stretch at a time. You're not able to fight off infection after that, so eventually it develops into necrosis and gangrene and potential infection of the foot otherwise. The way these guys are going to look initially is basically like this person does in the early stages. So usually the skin is initially at least pale and mottled. They likely will have some anesthesia to the foot itself, and it may be pulseless. It may actually be fairly concerning. We in fact had a person transferred up from another regional hospital for a pulseless foot that they thought was probably an acute occlusion. And when she got here, she was actually recognized as somebody that was kind of a frequent flyer to the emergency department. And the more you drilled down into it, the person really didn't have occlusion of any of their blood vessels. They had trench foot. So we changed her socks, got her some clean shoes, and off she went after that. It's important to go ahead and start rewarming these guys, and when you do, they can start getting hyperemia, which is just super redness or some purple discoloration. They usually get kind of a burning pain, which you kind of that feeling, when your hands warm back up and they start to hurt a little bit if you've been outside for too long. As perfusion comes back, you may get some bullae, like this person does over their joint on their big toe. The side effects of it, the pain and the numbness may actually last for weeks at a time. So that can be pretty miserable as well. And then if depending on how severe it is, they can actually have, again, tissue death like this guy's got at the end of his foot. They can get gangrene. You could lose bits and pieces of your foot. There's some pretty gnarly pictures online if you want to go check it out. The treatment for it is fairly simple. Number one, you want to warm the extremity. And number two, you got to get them out of the moisture. So giving these guys dry socks or shoes actually makes a big difference to them. This is something that if you think about how devastating it would be if you were homeless and then you lost a foot, what a terrible situation you'd be in after that. This is somebody that EMS may come in contact with and may be their only avenue to get into the healthcare system. So even if they want just their foot kind of checked out, you may be able to, if you have the resources available, potentially provide them a pair of socks, or we did a shoe drive one time so that we could give homeless folks a decent pair of shoes to walk around in. You got to tell them, take your shoes off when you go to sleep. Don't sleep in wet shoes or wet socks. And then you want to put dry bandages around any areas that you've noticed. And that also, if you're going to bring him to the hospital, that'll kind of help alert the hospital, like, hey, remember this guy's got bad feet before he leaves, and do something about it, would you? One of the other non-freezing injuries that you'll commonly see is chillblains. And this is the other name for this is pernio. And I can't remember ever actually diagnosing somebody with this, but it is out there. So this occurs in, same thing, damp, non-freezing temperature, so where you're losing heat from your extremities, from your distal parts of your extremities. And this happens to some people more than others, and we're not 100% sure why, but women and children seem to be affected mostly by it for some reason. It starts off basically the same way as trench foot I told you kind of started, which is the extremity gets cold, but here you get a combination of vasoconstriction, which causes more ischemia, and subsequently when you rewarm, you can find areas of bleeding or little bits of hemorrhage into the tissue as well, so you can get some red plaques or some swelling as you start to rewarm, and some blue nodules, which are essentially little bits of mildly hemorrhagic tissue. Most common place to see this is usually in the distal areas, in your feet, your lower leg, ears, hands, and it's basically just going to look like a cold, red, maybe swollen extremity or part of an extremity when you find it. The one difference between chillblains and trench foot is kind of a chronic thing. It has to have gone on for at least a while. Chillblains is something that you may see over the course of an hour or 2 hours, something like that. The treatment is essentially the same. You're going to warm the area, put a dry dressing on it, and keep it elevated. This is another one that'll bug the heck out of people, but it's not technically dangerous as long as you take care of the the affected extremity. So those were the non-freezing injuries. Again, that's just exposure to cold temperatures, but not necessarily enough to actually freeze your skin. The freezing injuries are basically all frostbite. So frostbite is a combination of skin freezes and then starts to die afterwards. And then there's this cascade of stuff that happens, essentially like a burn. And the most common place you'll actually see it is on the head, so earlobes, tip of the nose, followed by the hands and then the feet. Usually because the hands are the most unprotected area in folks that'll get frostbite anyway. Who gets frostbite? Well, it's mostly men. It's actually easier for women to get frostbite because you tend to have more surface area with less deep tissue underneath it, and so you can freeze a bit faster. But men tend to do it more because men tend to get it more because we're out doing stupid stuff without protection, or we get drunk and we go out in the woods in the middle of January with no gloves on. So anybody can get it, but men tend to get it more. It's increased if you have colder temperatures, of course. Things freeze faster if it's colder, but also wind speed makes a difference. So this is one of the National Weather Service charts about how often or how much you can be outside with unprotected skin and when you can anticipate frostbite to occur. So it can go from hours in just conduction through air to a couple of minutes. If you're exposed to a liquid, like if you have wet gloves or you have wet hands out in the cold, or it could even be in a couple of seconds. If you've ever seen somebody when it's really cold, if somebody grabs like an iron bar or a steel bar or something like that, bare metal that's very cold, you can actually get freezing of the tissues pretty quickly. So it doesn't have to be somebody that's just stuck outside in the snow for 6 or 7 days. There are some things that will increase your risk as well, other than just high wind speed and low temperature. So alcohol and smoking increases the risk of everything. No real surprise there. Of course, anybody that's not got proper clothing on is going to be more at risk to freeze. Folks that are putting on protective ointments on their extremities, you may wonder what that's all about. Well, if you put ointment on your extremities or on your nose or on your earlobe, it can actually increase the conductive cooling properties of your skin, and so you bleed off heat into the atmosphere a lot faster. So protective ointments can actually predispose you pretty significantly to frostbite. And then anybody with other medical conditions, atherosclerosis or diabetes, anybody with maybe impaired circulation is potentially at risk for frostbite more than your standard duck would be. Frostbite itself, I keep talking about it being a freezing injury, but just like a pothole, it's not the freezing that necessarily does the damage. Of course, you form ice crystals within the tissue and the cells, and then it can potentially rupture cells, and that's true, but it doesn't do that much damage in and of itself. At least the freezing part does. If you could keep it frozen, you'd probably be better off. What actually happens is this cascade of stuff when you freeze tissue, and then you get some cell damage, and then when you thaw out, there's a combination of endothelial damage. You get this arachidonic acid, and vasoconstriction, and blood stasis, and that eventually all leads to ischemia and tissue death. And just like a burn, you can kind of divide this into zones that kind of determine how much tissue is dead and what the tissue is going to do. So you have that dark area in the center that is frozen tissue in this case, and it's dead. That's not going to come back. But there's the area around it that is probably damaged, that if we take care of it, if we resuscitate the person appropriately and care for them appropriately, we may be able to save that tissue there. But if we don't do things appropriately, or if they refreeze and that tissue gets damaged again, then that tissue is likely to die as well. So frostbite is divided up into degrees, just like burns are. First degree is, again, just like a burn, basically redness, maybe a little bit of swelling in the area. There's a stinging pain, and we've all probably had a little bit of this. You were outside as a kid and did a snowball fight and you didn't have your gloves, and then you came inside and your hands warmed back up and you started throbbing and stinging. Mostly, there's not a lot of tissue damage that actually occurs with this. It's all in the superficial layers, and so as long as you don't get any worse, you shouldn't run into any problems with this. You just need to keep the person warm. Second degree frostbite is where you start seeing things like bullae forming. So you get swelling, the tissue becomes hyperemic and red, and you start getting blisters. And initially it's going to be anesthetic probably, but then you'll get an aching pain as you start to rewarm. And the changes on this can be fairly significant and look really bad. However, most of these do okay if they're properly cared for. And again, properly cared for means blisters are taken care of, they're appropriately dressed, the extremity is rewarmed and then not allowed to freeze again. Because if it freezes again, all this, potentially imagine all this pink tissue being at risk for dying as well, and then you can run into real problems. Third degree frostbite is pretty gnarly. So sort of similar to second degree, you can get bullae formation, but in this one you notice this guy's got some hemorrhagic bullae, where you actually get vascular damage. So this is down into the deep tissues where we're starting to affect blood flow. And you can imagine how when you restrict blood flow to an area that's injured, that things can potentially get bad in a hurry. So these guys tend to have like gray skin over the affected area. The area starts to look, pretty dead at that point. And then fourth degree is where it goes beyond the skin, past the deeper layers into things like the subcutaneous fat. Like this gentleman here, where the ring finger basically is necrotic at the end. You don't realize it right away until picture B, and then the tissue will demarcate and he ends up getting an amputation. So these guys may get flaps and stuff. So you get pretty deep burn here where you've actually affected the deeper tissues. The treatment for frostbite is sort of what you probably think it would be. Number one, you want to keep the person from harm otherwise. So if they've been out in the woods for 3 days or 6 days or however long, they're probably going to be in pretty rough shape. They may be hypoglycemic, hypothermic, they may be shocky. Whatever brought them to the state that they were unable to get themselves out of this situation may predispose them to being really sick otherwise. Now you can imagine that the last thing on the body's mind is getting blood flow out to the tip of their pinky finger when it can barely perfuse their brain. So you don't want to make the body choose between perfusing the tip of the finger and perfusing the brain. You want to resuscitate them vigorously, and what's good for the body will pretty much be good for the tip of the finger to some extent. We'll talk about that in just a second. Wet clothing is a really good conductor of heat away from the body, so you want to get rid of that. You probably want to immobilize the extremity to avoid it getting injured otherwise. Because remember, this is going to be essentially anesthetic at this point, and you don't want them whacking their hand against the rail or it getting pinched underneath the stretcher or something like that and them not be able to feel it. So keeping the extremity up and mobilized and dry and properly dressed is very useful. Now, there was always this thing that they said where, you can't warm these guys fast. You got to put them in like cold water, and then you can increase it to like tepid water, and then you can dump a little bit more, and you can get a little warmer, a little warmer, a little warmer. It's really, there's nothing that says that's actually true. You want to warm their extremity up, but you got to be kind of careful about how you do it. Number one, you don't want to warm them up if you think they might freeze again. So if you're rescuing somebody from a backwoods camp, and it's going to take you 2 days to get out, and you're not 100% sure that once you warm this guy's hand that you'll be able to keep it warm, it's probably better to let it sit and just not let it get a whole lot worse. Because if you get it warm over a fire and then we got to pack out a ways and you go 2 hours and then their hand gets cold again and freezes again, and then it gets warm again and then it gets cold again, every time you do that, that inflammation cascade kicks in and you cause more and more tissue damage. So it's much better to have not warmed it at all than to have warmed it and then frozen it again and warmed it and frozen it again. Dry heat is considered bad in these cases, and the problem really is that you can't regulate the temperature of that air. Like you can, a water bath, if you stick a thermometer in it and it says it's 100 degrees, it's going to be 100 degrees throughout that water bath. If you stick a thermometer in front of the heating vent that's coming out of the roof of the ambulance, it may say that it's 92 degrees, but the actual air that's coming out may actually be in some areas 160 degrees. which is kind of bad. So you can't really regulate the temperature of air very well. Plus, the person can't feel enough to tell you, oh no, that's burning pretty good. So dry heat is generally a bad thing. Using water baths, again, around 100 degrees, so hot tub kind of temperature, that's reasonable to do, and you won't hurt anything, again, as long as you can keep things warm. And then this does hurt like hell once it starts to warm up, so start doing some pain control. So that's the exposure injuries, and there's air quotes that you can't see that I'm doing right now. Exposure in, mostly we're talking about skin injuries and extremity injuries and that kind of stuff. To move into the broader category of hypothermia, this is a whole body hypothermia where the problem is that your temperature is less than what it should be. And there's a couple reasons for that, and we'll talk about why that happens. But why is it important? This is enzyme moving a glob of stuff through the cell down a piece of tubulin. Enzymes like this, and basically all of our enzymes, are designed to work between 35 and 37 degrees Celsius. So that's normal body operating temperature. Higher than that, they don't work or they stop working as well, and definitely lower than that, they don't work very well. And the most common place that EMS probably sees this and can actually view it is when you get a trauma patient who is bleeding. As they get colder, they bleed more because their enzymes don't work as well to help coagulate. So that's the most common place that you probably see it, but there's lots of other places that we can actually notice this. You might just not have recognized it so far. There's a lot of different ways to classify hypothermia. One of those is to say primary versus secondary hypothermia. So primary hypothermia is broadly thought of as somebody who is generating heat and their body knows that it wants to be at 37 degrees Celsius, but for whatever reason, because they're half naked and they jump into a pond full of ice water, or because it's wet and cold and 35 degrees outside and all they're wearing is a light jacket because they didn't expect to get caught in a rainstorm, they, for whatever reason, are not able to maintain that body temperature despite their best efforts to do so. So that's primary hypothermia. Secondary hypothermia is where the body basically is either not able to make heat or the thermoregulatory system gets reset and doesn't realize that it needs heat. So you'll find this with some medications, drugs, alcohol does this, endocrine problems, things like severe hypoglycemia or sepsis, cancer patients. Basically anybody who's sick is probably suffering from secondary hypothermia if they're cold. Acutely, hypothermia, depending on the cause, has a mortality rate of anywhere from between 17 to 80%, and part of that is just a marker of being, really super sick. Chronic, there is such a thing as chronic hypothermia, and those tend to be people that live in a cold environment. So old man who doesn't have a lot of resources, who lives in an unheated apartment where it's 50 degrees all the time, will sort of adapt at least a little bit to a lower body temperature. There's a big spectrum of hypothermia as well that goes all the way from, just a little cold, so just once you start dropping below 36, 35 degrees with mild hypothermia, down to severe hypothermia. And there's changes in your mental status and your cardiopulmonary function, and also in the ways that you might take care of these guys. So neurological is going to be one of the most easy ones to pick out. It's going to start as somebody gets cold. They're first going to get somewhat agitated and uncooperative. The next part you find, or at least we always found when we were out, say, camping in the winter, is somebody's getting cold when they have trouble walking. So somebody stands up from walking around the campfire and they aren't able to walk, or they drop their cup or something like that. Coordination is kind of the next thing to go, like those cerebellar functions. And after that, it's a steady slide down through confusion, into stupor, and eventually into coma as you continue to get worse and worse. The real problem is that once you start to get ataxic, it becomes harder and harder to self-rescue. So you can imagine somebody that's super confused and doesn't really know why or where they're at is going to have a hard time rescuing themselves from the environment themselves, or getting themselves warmer. It's also worth noting that you can get fixed and dilated pupils as a result of hypothermia itself. The coldest person I ever touched that was still alive was a college student who, on the coldest night of the year, went out in his shirt sleeves. He was drunk, of course, fell into a snowbank next to the road and wasn't discovered until the next morning. And when he got to the hospital where we went and picked him up from, his body temperature was about 80 degrees. By the time we got there, it was up to about 82. But we did all the rigmarole that we'll talk about in a minute. And as we were transferring him back, we looked again and noticed that he had one pupil that was fairly significantly large, and the other was essentially midpoint, but neither one were really moving. We were worried he might have a head bleed, so we did things like start hypertonic saline and tell the trauma guys about it. It turned out that he didn't have any head injury, but the antisequoia that he had, the big fixed dilated pupil, was just a result of his hypothermia itself. So that can be a little bit of a misleading element when you see these folks. Did they actually have head trauma, or are they just super cold? You'll see some pulmonary changes as well. Initially, when you get cold, you breathe a little bit faster, and then quite a bit faster, and then eventually, as you get cold enough, you'll lose the drive to breathe, and you'll have pretty low, shallow, decreased tidal volumes. There's such a thing as cold-induced bronchorrhea, which basically means you get not pulmonary edema, but edema into your bronchus, so you can cough up that kind of frothy sputum like you might think from a CHF exacerbation or something like that. And it will cause you to have depressed airway reflexes, so it's potentially somebody that could be at risk for aspiration if they're super cold as well, so have a low threshold to gently control their airway if possible. We hear about the cardiac changes a lot in school because it's an easy thing to look at. And there's a fairly stepwise progression in this. So you can have almost any change once you start to get below 32 or 30 degrees, depending on who you look for. Probably more like 30, but they say it could maybe happen, at least some blocks, as you get down to like 32. You can, again, have just about any kind of EKG change, but the most common one you're probably going to see is a sinus bradycardia. The one that you will probably hear about more would be a slow AFib. So irregular, no coordinated P-wave activity in AFib, but with a slow ventricular response. So there's basically two things on a test that will give you AFib with slow ventricular response. One is digoxin poisoning, and the other is hypothermia. And you also get development sometimes of these in V3 or V2, these positive deflections at the end of the QRS. And we'll see those again in just a second. These are called Osborne waves. And if you look here in V4, V5, V6, right at the end of the QRS, there's a second little hump, almost like you might expect a right bundle branch block to create. That's an Osborne J wave. And it's classic for it, but you don't see it all that often. When it does show up, it again looks something like this. You're going to see it in the precordial leads mostly. It's associated with the degree of hypothermia, allegedly. So while you may see relatively small ones like this, where the guy has a core temperature of maybe 28 or something like that, in this cat who's 25 Celsius, you look at these giant J waves at the end of his QRS in V2, V3, V4, and V5. So not a STEMI. It's not it's not ST elevation. It is the actual elevation of the J point itself, this little hump. So again, Osborne J waves, and the height of that is supposed to be proportional to the degree to which the person is cold. There's other things that happen too. Again, all your enzymes are going to kind of shut down, so you're not going to be able to use sugar effectively for the most part, and so you can get into a state of hyperglycemia. It's probably not going to be, profound like 1,000, but it certainly wouldn't be out of range to be 200 or 250 in the setting of severe hypothermia. You can get decreased liver function, and so things that get metabolized through the liver won't go away as fast. So some benzodiazepines, for instance, you may give a touch of, pick whatever, a touch of Valium potentially for sedation if you need it, and that may hang on for 2 or 3 times longer than it would otherwise, sometimes even longer than that. So just kind of keep in mind that any drug that you give is going to be kind of enzyme dependent, and it's probably going to last for a while longer or may not work at all. You can get a cold diuresis, which is where you basically have significant fluid loss, and so these folks can be volume down, despite the fact that they're not out in the heat, they're out in the cold. But you can potentially have fairly significant hypovolemia as a result. And some folks can even get so much going wrong with them, they develop almost a DIC picture, so they get some intravascular clotting. What's the treatment for hypothermia? Well, it's get the guy inside, out of the snow, and tell him to put on some pants, for God's sake. So we want to change the person's environment to where they are no longer losing heat, but actually gaining heat from the environment themselves. And that gaining heat from the environment is the really important part. So it's important to get rid of wet clothes and dry these people off. There's a statement about handle these guys gingerly, gosh, you can't push on this guy because he's really cold and you could precipitate VFib, and that's supposed to be out there, and it is. It's a real threat because your myocardium is unhappy and potentially easily stimulated, and you can precipitate ventricular rhythms coming out if you deliver a blow to the guy, sort of like a little tiny lightweight precordial thump. However, it's probably not going to happen if they're above 30 degrees. It's probably not going to happen unless you really give them a decent thump to the chest or a decent change in the motion of the chest itself. So it's okay to move them onto a bed. Just don't drop them onto the bed. It's okay to intubate them. You want to kind of avoid doing chest compressions on them if they actually have a pulse still. Because when you do that, if you've got somebody that's in a bradycardic rhythm and still is generating perfusion, that's better than putting him into VF when you start doing chest compressions, because something like chest compressions really can actually precipitate VF in these folks. Remember that when you stick a thermometer in the guy's bottom as well, you may get a core temperature of 80 when his core temperature may be actually 95, 96. So if at all possible, if you have an esophageal temperature probe, or if you're at a hospital and you're going to transfer the guy, if they can do a temperature sensing Foley, that's a little bit better. Remember that something from the core itself is really important, because we really want to know what temperature his chest, the middle of his thorax, is at. Again, keep in mind that his pulses and his breathing may be shallow to nigh undetectable, so you probably want to do your initial pulse check before you say this person does not have a pulse. Give it at least 30 to 45 seconds, unless the person's clearly in asystole on the monitor or is in VFib, in which case there's no chance they're going to have a pulse anyway, so don't worry about it. If you are called to one of these guys and you find that they have arrested, they're in VF or they're in PEA and you're sure there's no pulse and they're not breathing and they're unresponsive, what you should do is focus on getting them warm, because everything else that you are planning on doing is only a temporary measure to get them to the point where they get warm, and they will not get better until you get them warm. So that's got to be first on your mind. But if they are pulseless, you should begin CPR. Can you defibrillate these guys? Yeah, but if they're cold, it's not all that likely to be effective. So the guideline right now is probably defibrillate once, and then if it doesn't work, do CPR and focus on getting the patient to someplace where you can get him warm. How about using resuscitation drugs? You can. Sometimes they work, sometimes they don't. You may either need, depending on the drug, more or less of the same drug than you would normally use. Intubation-wise, again, be sort of careful about it. Be mindful that these guys' jaw may be sort of stuck, so it may be a difficult intubation, and you don't want to get in there and muck around too awful much. Finger stick is worthwhile just to kind of round things out, and keep in mind some of these guys will be hyperglycemic and some will be hypoglycemic. When we talk about warming, that's sort of the key to this whole thing. How do you actually warm somebody up in the field? Or for that matter, if you're transporting the person, say from one facility to another, how do you maintain that heat? Well, the first thing everybody wants to do is get them out of the cold. And yeah, that makes sense. But keep in mind that the temperature inside the ambulance or inside the hospital even is probably going to be somewhere between 70 and 80 degrees because it's too stinking uncomfortable for the providers to be much, much warmer than that. So the warm environment still, if you let the person tend to that warm environment, is not going to be warm. It's going to be room temperature. And you don't want the person at 70 to 80 degrees. You need them at 90 plus Fahrenheit. So the warm environment thing is not all that great. To kind of demonstrate this, what I did this morning, I wish you could see what I'm handling right now, but it is about a 2-pound lump of top sirloin. So I got this out of the fridge this morning and measured the temperature with a digital thermometer. It's 46 degrees. I got him out, plopped him on my desk, and let him sit there for about 2 hours getting ready for this talk. His temperature at that point was 48 degrees. Okay, well, we've made a little bit of stride, but not all that much. And again, this is a cold piece of meat. So the warm environment itself was not very helpful. I then took a blanket and wrapped it around the piece of meat and let it sit for about a half an hour. And on recheck of the temperature, it was 48 degrees. Keep in mind that a blanket works by insulating what heat is already there. So if they are not generating heat, then the blanket is not really gonna help them get that much warmer, at least not very fast. What about a warm blanket? I wrapped that around the piece of meat, and it stayed the same, still 48 degrees. Warm blanket is nice in that you don't have to warm it up with your body heat, but it doesn't add heat to the patient itself. Very shortly, it's going to go down to the same room temperature that the rest of the bed is at. What about warm fluid? I don't disagree that warm fluid is better than cold fluid. Probably everybody that we're resuscitating for any reason, medical or trauma, if they're going to get fluid, it should be warm. Warm fluid, however, doesn't really warm up the person, because it's generally heated to about body temperature, so somewhere around 96, 97 degrees, depending on where you're at. So it won't really warm up the person because there's just not enough of it. There is 200 pounds of cold tissue, of cold meat that you need to warm up. And that one little 96-degree bag of IV fluid that weighs 2.5 pounds thereabouts is just not going to be enough volume-wise to really impart a lot of heat to that person. So warm fluid, good, but don't think that you're really doing the person a whole lot of favor by by doing that, at least in terms of getting them warm. You're just preventing them from getting colder like you would if you gave them room temperature fluid or 50-degree, I've been sitting in the ambulance all night fluid. Warm inspired air is a great way to actually warm somebody up. And usually you have to have a ventilator or a fairly advanced ventilation system for that, because you certainly don't want to try to rig up something with the heater on the ambulance or with a hairdryer or something like that and give the person actual thermal burns. See before our discussion on why you shouldn't use dry heat to warm somebody up. Your lungs work real well for this because they're basically like a radiator. Radiator's got a lot of little pipes inside it and a lot of fins, and water passes through there and disperses heat out into the environment. In your lungs, you're going to do basically the opposite. There's the little pipes are the blood vessels, and the airspace is the airspace. And so you've got lots of little holes where blood vessels are in intimate contact, and blood runs through there. And if it's got warm air, it can pick up heat and disperse back out to the body itself. So using warm air is a really good way to go if you can get it warm enough and if you have enough time. It would be really awesome if everybody out there had a ventilator that could adequately warm air to a point that's not actually going to hurt the person. But that doesn't usually exist in the EMS world. So kind of count that as, sure would be nice, but maybe it's not actually going to happen. So what's the best way to actually get somebody warm? Well, usually it's through some kind of either heater plus insulation or a forced air blanket like a bear hugger. And I have put a bear hugger on an ambulance before. It made the trip. I can't guarantee that it would work in every ambulance or with every bear hugger, but it worked for us, and it actually got the guy, got his temperature up by about 6 degrees by the time we made the hour or so trip to the hospital. So forced air blanket, very effective. In absence of that, what you can do is potentially take some kind of heating pack. And again, you don't want this to be hot enough to burn your skin. And keep in mind, lots of stuff will burn your skin if you leave it in contact with it for very long. But say you've got a 100 to 110 degree water bottle, put those in the axilla and the groin, maybe on the hands and feet, and then wrap a blanket around those folks and maybe wrap an emergency blanket around that and very carefully monitor all those sites. And that will help to get the person warm, at least relatively quickly, as quickly as you can in the pre-hospital setting with nothing else out there. In the emergency department, we start talking about putting in chest tubes, and you put one chest tube in the front of their chest and one in the back, and then you start infusing fluid through that, and the idea is that, again, bathes the lungs. As blood flows through the lungs, they pick up that heat, transmit it to the rest of the body. This is not as easy in practice to put together as the diagram would sort of suggest, but I have seen it done. I've done it a couple of times, and it's hard to even describe to people what it is you're trying to do. Probably the most effective way to get somebody warm is to get them to the hospital and either put them on cardiopulmonary bypass or on ECMO, and that will work, but it requires you to be at some place where they can go on cardiopulmonary bypass or ECMO. So there's that. Maybe if we get ECMO in the field at some point, we can talk about it. How warm do you actually want these people? We talk often about you can't be cold and dead, you have to be warm and dead. So the idea that you have to bring the person up to some temperature before you can say that they have officially died or that their arrest is complete is sort of bandied about out there, but how warm do you actually have to get them? The answer is probably to about 90 degrees Fahrenheit. Below 90, above 90, the chance of dysrhythmia is relatively unlikely if it's primary hypothermia. So if you bring the person's core temperature up to 90, or if their temperature is above 90, and they are in asystole, and you terminate people in the field, then that's probably okay. The guy that's 85 is not quite ready to be called yet, unless you think the person died from something other than primary hypothermia, meaning they had a heart attack and we found him 3 days later and he was 32 degrees because he'd been outside for that long. So folks have been resuscitated from as low as 14 degrees Celsius and actually do fairly well afterwards. There is some neuroprotective component to being that cold. Certainly not everybody that comes back from that is going to be a tax-paying citizen or is going to go back to their job as an anesthesia resident, but some people will. And so it's worth giving everybody the shot, if nothing else. And we can determine in the light of the emergency room where it's 72 degrees with low relative humidity, and there's lots of people standing around, if we need to keep resuscitating this person further. I'll briefly hit on submersion injuries here. And this is really not so much a drowning talk as it is a cold weather talk, but submersion can happen not just in the summertime, but also in the winter. And usually this is a kid falls into either an uncovered pond or a pool or breaks through the ice. So it's, again, a bimodal age distribution. It's young kids who can't swim or don't have the sense to stay out of the water and get themselves into trouble. And then it becomes older-ish teenagers, so 16, 17, 18-year-olds. Testicles plus alcohol equals bad shit happening. And that's a fairly clear rule to me. We used to say this stuff about wet drowning and dry drowning, and you can basically just avoid all that. Basically, when someone has fluid that prevents air from going into their airway and eventually down into their lungs, then that's somebody who has drowned. That's what drowning means. And whether it was just a tiny little bit of fluid, and there's fluid in their lungs, there's fluid not in their lungs, it doesn't really matter. The common pathway for how these people actually go down is they fall in. They go under the water and they hold their breath. And you hold your breath and hold your breath and hold your breath and hold your breath, and your brain finally overpowers your good senses and says gasp, and you go, and then you get this this water rush in, and you get laryngospasm from that. And then you can't breathe, and eventually you pass out. Eventually, your body tries to breathe again because it hopes that maybe if we didn't breathe right now, we'll have floated up to the surface and maybe we'll actually be okay. When you try to take that breath after the pass out, that's when you actually breathe in water. So you could have a fair amount of water in the lungs or not that much water, and it's really difficult to demonstrate that. Water in your lungs, as much as anything besides being a direct asphyxiant, also alters the surfactant and can lead you to an ARDS type picture. So even if you're only went under, but if you took a big breath of water in, you can still have some pretty significant pulmonary complications in the hours following. What about cold water itself? How long do you actually have to get out of cold water before it starts causing problems? Basically, if you jump into water you've got about 2 minutes, and we've all probably done this if you've done any kind of like polar bear plunge or anything like that. You jump in and you go, oh my God, that's cold. And for about a minute or so, maybe up to 2, you are in this cold shock where you can't do anything. You're sort of paralyzed. You gasp, you hyperventilate, you get this big sympathetic reflex. Kids more than adults will get the diving reflex where you get bradycardic and potentially pass out. Sometimes that does happen. But if you're able to kind of hold on for that first 1 to 2 minutes, you've then got a period of time up to about 10 or 15 minutes where you can still meaningfully use your extremities. You develop a functional disability, again, between about 10 and 15 minutes. But up until that time, that's your best chance to self-rescue if it's going to happen or to tread water. It actually takes about 30 to 60 minutes of being in pretty cold water for your body temperature to get low enough that you would suffer the effects of hypothermia itself, of significant hypothermia. So the rule is basically 1 minute, 10 minutes, and 1 hour. And after an hour, it's very hard to come back from that. You'd probably be pretty profoundly hypothermic, at least in cold water. Treatment, of course, is to get the person out of the water, to warm them, dry them. If you need to manage their airway, remember that these guys are basically going to have a picture that looks not unlike a severe multilobar pneumonia or bad CHF, something with a lot of fluid in the lungs. So high PEEP may be needed, probably low tidal volumes, and probably a relatively high respiratory rate if you're going to do that. So PEEPs of 12, 15, something like that, even higher, depending on what your equipment is, may be necessary. Do you immobilize these guys? It depends on the history. The chance of a cervical spine injury from a submersion event is less than 1%. So as a rule, no. It's very unlikely. If you got the story that he jumped into the ice-cold pond head first and it was only a foot deep and you saw him standing up by his head essentially, and you're concerned about a C-spine injury, then yeah, that makes sense. But for the most part, cervical spine immobilization is probably second to getting the person's airway managed and getting them out of the water and getting them warmed up. Just remember when you're dealing with the drowning part that it's not a cardiovascular problem. So where we've kind of gone to doing CAB in terms of CPR and that kind of stuff instead of ABC, this is an ABC kind of problem. So the airway and the breathing are going to be their primary thing. Even somebody that's still breathing after they come out of the water can progressively get more and more dyspneic to the point where they initially just needed a little bit of oxygen, and then they needed BiPAP, and then they get intubated and put on a whole bunch of PEEP. If they're wheezy, you can give them albuterol. There's some bronchospastic components to this as well. Generally speaking, these guys won't be so shocky. Their problem is going to be airway itself and their saturation. So fix the airway, fix the saturation in terms of drowning, and hopefully you won't have to do too much with their circulation part, unless they're hypothermic, in which case the treatment anyway is to just get them warm. So that's enough about that. That's hypothermia and wintertime kind of injuries for you. It should be warming up soon, so hopefully we won't have to deal with it much longer. But keep in mind that these variable temperature times are when people are most likely to suffer these events actually. So when it's 60 degrees and raining one day and the next day it's 25, that's when people really get injured and can really get hurt by this stuff. If you have any questions, let me know. Email address is emsgrandrounds@gmail.com. If you'd like to present or you have a topic that you think we should talk about, just let us know. Again, emsgrandrounds@gmail.com, all one word. This is Walt Lubbers signing off for EMS Grand Rounds.